Hello, welcome to the Pro presentation for week 8.2, Introduction to Crisis Intervention, Trauma-Informed Therapy. Within this review, we're going to cover quite a few points listed as following: models and strategies related to suicide prevention, crisis intervention approaches across the span of available services, client assessment of previous trauma connected to suicidality, homicidality, ways to identify and report signs of abuse or neglect, trauma modalities that are well suited for clients who present as suicidal or homicidal. Models and strategies for suicide prevention include exploring trauma related to a suicidality includes a clear multi-layered prevention strategies. Numerous agencies and organizations, SPRC, which is the Suicide Prevention Resource Center.org, and SAMHSA.org, founded evidence-based approaches that offer successful strategies that include identifying and assisting persons at risk, increase help seeking, ensure access to effective mutual health and suicide care treatment, safe support care for transitions, effectively response to those in crisis, provide immediate and long-term postvention to reduce the risk for those impacted or bereaved by a suicide, and reduce access to the means of suicide. So that would be limiting firearms, weapons, those instruments of self-harm. So these are models and strategies of suicide prevention. Certainly not all, it's not limited. These are just some that are by organizations that are nationally recognized. So SAMHSA, National Institute of Health, the CDC, the WHO, all recognize these particular points as verified effective strategies and models. The result would be to enhance life skills and resilience and promote social connectedness and support to further continue with the strategies and models of prevention. Now, this is their graphic from the website, Suicide Prevention Resource Center. So I have, we have all the points here: comprehensive approach to suicide prevention, care and effective treatment. All of the points are listed in that graphic. Reduce access to means, life skills, and resilience. So everything is connected and not necessarily in any particular order, but that really depends on a case-by-case basis as someone is in crisis. The assessment and the needs for how these are approached are independent and unique. Crisis intervention. What is a crisis? Crisis could be a natural disaster or a traumatic loss, a sudden loss, or a tragic event. Scholars once accepted a crisis as a four-stage paradigm. So it was viewed as a linear phenomenon. So it would be exposure to a stressor, an attempt to restore normal function, a marked failure to be able to return to normal function, a behavioral emergency connecting to cognitive dysfunction and dysregulation, and a subsequent breakdown of physical and psychosocial health. And that's from Gerald Kaplan. That's from 1964. So that's considered an early model of what a crisis is. That's still considered, while that's a linear model, some of those points do still apply. It's not a given for any and all crises, but rather to be taken on a case-by-case basis. So in recent decades, scholars have come to accept crisis intervention as dynamic. So some, but not all, and certainly not limited to those points. So crisis versus trauma. So what is the difference between the two? Well, crisis is typically an abrupt event that creates a disruption in normal function. Trauma typically refers to the effect or impact of the crisis experience. There is also the term that we reviewed called transcrisis, which is crisis that occurs that is yet unresolved while there was a previous unresolved crisis, and then another crisis occurs on top of that. So you have multiple crises which result in a different type of trauma that has to be kind of unpacked and dealt with appropriately therapeutically. Crisis intervention, some basic points, and these are from the James textbook, and I included these because they just create a really good grounding for how we come to understand a model for crisis intervention. So initial contact, establishing a predisposition or receptivity to assistance is demonstrates your willingness to speak or work with a counselor. So this is when you initially reach out to someone, if they're in crisis, if they are open or receptive to a conversation, that's helpful. The next step is to define the crisis. So figure out what exactly is going on, how it's understood by the person that you're trying to help, so that they can kind of articulate it and get a sense of what's happening. Obtain at least enough information to understand the stressor. So through this description, we can get a sense of the crisis and the impact for that person experiencing it, which might be different than the person right next to them that may have experienced the same thing but internalizing it differently, maybe understanding it differently because it's impacting them in a different way. So being able to define the crisis from the perspective of the person who experienced it. Once the crisis is understood, consider the available support. So like the psychological first aid, it's important to consider the psychological, social, and logistic support that might be needed. So if someone lost their house in a fire, like in California recently, there's a lot of things to, a lot of moving parts that need to be coordinated. So it's not only the psychological loss of one's home and all of their possessions, possibly loved ones and family pets, but also the social aspect of their loss of community, their neighbors, the uncertainty of knowing what's going on, what's happening to people, and the logistics, just the basics of survival skills, a roof over one's head, a meal, what's their next meal, is there availability for lodging and housing and childcare, and these things that were consistent within the community, which are no longer consistent. So logistics are an important factor in figuring out available support. What does someone need, and what are the resources to get it? Consider alternatives within situation support and coping mechanisms, constructive thinking patterns. Consider how the client can get to a place of empowerment. So considering alternatives relates to if one resource is not available, is there another resource that might be available? If there is something that the client needs that may not be available within the regular spectrum of available services, maybe there's something unique that the client needs. So it's important to kind of note and understand what some of those things are. Also, if resources, which typically resources are limited, if they're not available, you need to find an alternative way to find those needs, to get those needs met, so that that person can get what they need. Next step, make plans. It's important because crisis situations often result in chaotic and unconnected events. Planning establishes essential directives. Making plans, when there is a chaotic situation and you feel that there is no control, sometimes if you can have a plan, it kind of empowers the client to feel that there is a sense of control in something. So there's a plan to, okay, we're going to connect with agency X, Y, and Z and get services for housing. Then we have another agency that's going to deal with immediate food assistance. Then there's another agency that will connect or coordinate with FEMA to possibly get, let's say, in the event of a natural disaster or fire, get the services needed to file with insurance and go about the process of rebuilding a home, or in the immediate crisis situation, provide housing or something that is essential, immediate for survival. This would include housing for family, housing for whatever is needed. So making that plan helps to regain a little bit of a sense of control there. Obtain a commitment. So this would look like, for example, someone who has lost everything and they're in crisis mode, and you work with them on points that are part of the intervention. Obtaining a commitment is a commitment from them that they will follow through, that they will, yes, they will call the FEMA coordinator the next day, or as soon as they get their phone charged up, that they will have the access to call that FEMA coordinator, and then they'll circle back to another coordinator, or that they will know the next steps moving forward and that they are committed to following through with those steps. Likewise, if there is a different type of crisis situation, not necessarily a natural disaster or fire like in California, but if it's on a personal note, like a school shooting, for example, these same points would still apply, because that's all within the same paradigm of crisis intervention. So making plans would look like making plans with, if there was a school shooting, for the handoff for counseling, follow-up therapies, to consider the best steps moving forward. Obtaining commitments might look like coordinating with the appropriate outreach counselors and finding out, getting the commitment on, what the next steps are. Follow up to ensure appropriate handoff. This is important because in a crisis state, crisis intervention, there is this point in the process where there needs to be a handoff from one agency to the next, or from one counselor, from one helper to the next, so that it would be the first point of contact would then say, okay, well, I can help you with this, I can't help you with X, Y, or Z, but I'm going to connect you with the person that can. So that way you are basically handing off. Now you will also have to follow up. So the handoff has to be in an appropriate manner. So if it's natural disaster and someone is in crisis and they are trying to organize the logistics, you're trying to organize the logistics of housing, childcare, and medical attention, the appropriate handoff would be to coordinate with the person in charge of medical, the person in charge of housing, or the person in charge of food distribution, and walk them over there and say, Joe Smith was a part of this crisis, part of this catastrophe, lost his home, and I'm going to pass him off to you because I know you can help. I told him that you would help him coordinate housing and work on some of those logistics. So you're following up with the other entities that are involved in the process, so that the person who is being helped does not feel that they were abandoned, so that you kind of carry through with that. Assessments used for this multi-part presentation. It's important to assess in a crisis situation, especially when there's a concern for suicidality or homicidality. So a triage assessment form, that's a go-to, that's a basic one, and that's used to assess across 3 domains. So it's emotional, behavioral, and cognitive across those areas. And it's often used by police and first responders to kind of gauge a sense of where someone is. What is their level of impairment? Are they hysterical, or are they simply a little agitated? Are they argumentative? Are they physically fighting? Or are they simply, are they not putting up a physical sign or a behavioral sign of distress? Cognitive areas of thought. The triage assessment form looks at cognitive areas in that there is a consideration for is the person in crisis thinking clearly? Are they able to understand where they are and what day it is and what has happened to them? And are they able to respond in that way? The next assessment, and again, these are just a sampling of assessments. These are by no means limited. There's many different forms of assessments that are nationally recognized and accepted by the CDC, WHO, National Institutes of Health. These are just a few that I've pulled for sampling here. Adult Crisis Assessment Tool, the ACAT. It's specifically, this one is geared for adults who are 21 or older. There is a child version of this, child/adolescent version of this. There's the Columbia Suicide Severity Rating Scale, and this is specifically for suicidal ideation, and it assesses the severity or degree of someone's likelihood to self-harm. So this would be, do you feel hopeless? Do you have thoughts of suicide? Do you have intentions? Do you have ideas? Do you think about it with an intent to act on it? Things like that. So the Ask Suicide Screening question. So this one is just a short assessment screening tool used just in a really quick, to often medical setting, a medical assessment environment. So let's say there's been a like first responders, for example, might use this as just a real quick assessment. It's by no means the last assessment or an extremely thorough assessment. It's really a generalized topical assessment to just kind of get a sense of where the person is as far as suicidality is concerned. Signs of neglect or abuse. Now, this is another one of those essential points within the review. So the National Institute of Health identifies indicators of abuse, which would include low self-esteem, guilt or responsibility for abuse, physical signs like marks, scrapes, cuts, bruises, broken bones, verbal abuse, which sometimes happens in front of others, fear of outside influence, damage to home or surrounding property, and isolation. The National Institute of Health, with other national organizations, has a very similar standard by which, similar indicators for what is considered abuse. So often using something like a detailed intake interview, a simple discussion, mental status exam is one, can really provide a lot of clues about an abusive situation. If someone is not hygienic, if they have not bathed or washed, or they look, they're missing something essential. Let's say it's cold out, but they don't have a coat, or they're a child without shoes, or malnourishment or dehydration. There's a lot of very obvious and outward signs that may not be obvious and outward signs that would indicate signs of abuse. And at the same time, there may not be obvious and outward signs, but there might be low self-esteem or things that are not overtly visible, like bruises that are hidden under clothing, or injuries that are not obvious initially. So it may take a little bit of time to find that. All right, so trauma modalities, especially for patients or clients, that present with suicidality or homicidality. These are what is nationally recognized and is considered effective for those clients. So specific care principles always include safety. Everything goes back to safety, but also in collaboration with the client to empower them to continue with therapy. There's a focus on strengths, possibly cognitive reframing, CBT, psychoeducation, and this is all from the SPRC Resource Center .org, and we also have CBD and DBT, effective options for also trauma-focused cognitive behavioral therapy. And this is a tricky one. So with trauma-focused cognitive behavioral therapy, it's a little more, it's trauma-focused. It's cognitive behavioral therapy that's trauma-focused with a little bit of reframing, where you slowly go back to that original crisis and review that trauma and work through it and in a little bit more of a healthy way. Also, there's exposure therapy, but that one tends to be, that is a proceed with caution. Exposure therapy, you have to be, I would want to be conservative with that modality of treatment, because depending on the trauma and depending on the crisis, it's kind of a tough one. PTSD, research indicates that with PTSD, within like a military campaign for veterans to do the exposure therapy tends to be really difficult. Anyway, but I have that in the resources at the end. Interventions. So conclusion, interventions included in this review, as well as assessments, approaches, and essential points, are all part of a broader approach to safely intervene in crisis situations. So the idea is early intervention in a crisis will help prevent long-term trauma. So trauma unresolved, untreated crises often presents as dysregulated, cognitively dysfunctional individual unable to resolve equilibrium and mobility. Data supports intervention early at the point of initial crisis, which allows for healthier outcomes with regard to long-term trauma. Assessments reference. So I have some of the assessments right here that were included. The Columbia Suicide Severity Rating Scale. This is important for suicidality. The ACAT, and then the guide is also included. PFA, this is the psychological first aid assessment, or website rather, with assessments included. So this is on the ground basics. A lot of first responders do the certification course. It's not just for clinical mental health professionals, it's for anyone working on the ground. Basic references from the Bellevue University Library, articles, scholarly reviewed articles, textbook included, more references, and then a few websites that are very helpful in doing some research. Prevention, comprehensive prevention approaches, National Institute of Health, PTSD, and WHO websites with some information, CDC also information included. And that looks like that's our time right now. And I think I needed to include a few minutes of a question and answer at the end. If anyone has any questions also, there is some important to note as an activity along with this presentation, that when you deal with crisis intervention and you're walking and you're working with those that are affected by trauma, it's important to practice self-care. And self-care, of course, you can ground yourself and practice some deep breathing and mindfulness exercises. So as an important aside that kind of is an adjunct to this, consider the health of the counselor, the self-care that we need to take care of as we are trying to be the helping profession. So anyway, I think that's it. I've enjoyed working with you. Thank you so much for giving me your time and letting me share.